This lectureship was established in honor of nurse educator and former faculty member LaVerne Gallman. But there's more to that story than the biography that is described on your program, and I'd like to just take a few minutes to share that with you very briefly today. Dr. LaVerne Gallman was not just a valued faculty member who was on our faculty for many years, but she also served as the graduate advisor at the school and helped hundreds and probably thousands of students, including this one, find our way through the bureaucracies that frustrated us and the challenges that confronted us. She was a kind and gentle person who always expected the best from each of us and fully believed we could do it, and believed that we would all change the profession of nursing and the world. This lectureship is funded by an endowment, and for those of you, especially students, who might not know what that means, endowments are forever funds, and that is that a certain amount of principal is dedicated to the endowment, to the gift, and then only a portion of the interest is used each year to fulfill the planned purpose of the endowment. Typically, one wealthy donor decides to establish an endowment in honor of a person or a cause or something they want to have happen. But again, this one was different. In 1984, several of our recent doctoral graduates and students pledged $500 each to start the fundraising to establish this lectureship. I was a student then. $500 was a lot of money for them. It was certainly more than I had. But the donors for this lectureship, as they did their fundraising among all our current master's and doctoral students and our graduates, people gave from $25 and up, and eventually raised $26,500 to create this endowment. At the time, I remember when they started this process, and I thought, well, it's impossible. We will never get to that huge goal. But you know what? We made it in a year, and it was the students and the recent alumni that made that happen. That endowment is now worth more than $250,000. So I want you all as students to keep that in mind. Those gifts that you give that can go on and grow in perpetuity, we will be having this lectureship for many, forever, essentially. The UT system had a process then where they matched endowments, and so it was originally established in 1985. So just 1 year it took those students to raise this money. Dr. Gallman was thrilled with the honor of a lectureship in her honor, and because she saw it as a way that, not to honor her, but a way to bring different voices to campus, to bring distinguished lecturers, bring attention to the extras that students at this university should have access to. She retired as Professor Emerita, I believe, in 1992, but in subsequent years she would drive down, and she did drive, down I-35 from Temple, Texas, and we sort of had a prayer service, on the way. But she would attend every lecture, and she was so, again, happy to see students in particular. So I know I saw a lot of our doctoral students walk in, and she would be so happy to see you all attending this, and students in general. When I would talk to her about upcoming plans and invitations, what she thought about who might be the lecturer for that year, she'd say, Alexa, whatever you want, whatever will help the students. And that was what she had lived in her life, and she saw this lectureship as. Sadly, she did pass away in 2013, but her influence and support of this School of Nursing and our graduates and graduate students lives on through this lectureship, and also a graduate fellowship that was endowed in her honor. I know that she would be pleased with the lecturer we have with us today, Dr. Bill Tierney, a general internist, a medical informaticist, and a health services researcher, who most importantly serves as the inaugural chair of the Department of Population Health at the Dell Medical School. Dr. Tierney is internationally recognized for research in biomedical informatics, health system improvement, and clinical database epidemiology. Prior to coming to UT Austin, he did have a life before Texas, although I'm sure he's forgotten it. He was in Indiana, but now he's from Texas, we have to say, where he was president and CEO from 2010 to 2015 of the Reagan Street Institute and associate dean for research at the Indiana University School of Medicine, and chair of the Department of Internal Medicine for Eskenazi Health, the nation's fourth largest safety net health system. So he's never had much to do, just a few jobs. Dr. Tierney was the founding director of informatics and research for the academic model providing access to health care AMPATH is the acronym, a now 38-year collaboration of more than 20 North American universities, led by Indiana University, and this collaboration is with Moi University in Kenya. And we're so pleased to have guests today from there, and he'll be introducing them in a moment. Since 2005, AMPATH has received more than $120 million in research funding. And Dr. Tierney was also the founding director of the Regional East African Center for Health Informatics that created the Sub-Saharan Africa's first ambulatory electronic medical record system. Dr. Tierney has received many recognitions, and I could take the entire time telling you those, but those have included his election to the National Academy of Medicine in 2006. He's also a Master of the American College of Physicians and a Fellow of the American College of Medical Informatics and an inaugural Fellow of the International Academy of Health Sciences Informatics. Please join me in welcoming our distinguished lecturer, Dr. Bill Tierney.
Thanks, Alexa. Is this, can that be heard okay? Okay, so just to get kind of this out of the way, I've got a lot of conflicting interests, but no conflicts of interest. So I'm going to tell you a story that has evolved over a period of 40-some years, and how I got involved in that and how it was life-changing for me and many people who are engaged in it. And it starts with this man. And he'll show up a lot during this. This is Joe Mamlin. This picture was taken in 1970 when he returned from a 6-year stint in the Peace Corps in Afghanistan to establish one of the first divisions of general internal medicine in the country at Indiana University. Mainly focused at a thing called Wishart Health Services, which is now Eskenazi Health, which you just heard a second ago. Joe was asked to do this and did so by inviting several of, not many, it was actually 3 of his friends that he met in that service to come and join him to build an inner-city primary care system. And so it's always had a touch of global health, because everybody involved initially had global health entanglements and continue to go back and forth between Indianapolis and various places on the globe. During the Russian invasion of Afghanistan, the division always had a couple of Afghan refugee physicians that would spend part-time there and sometimes resettled in the United States with the help of the division. So it's always had a global health engagement. In 1979, I became Joe's, I guess it would be his 9th chief resident, which running the inpatient service of this 540-bed hospital. And then in 1986, Bob Eintertz on the left became his chief resident. Bob is another general internist. And Bob had a long family history of involvement in global health. His sister, until recently, was still based in Cameroon. And Bob, after he finished his chief residency, went and spent a year in Haiti and came back and met with Joe and the original founders of our division. And he said, "You know what just happened to me. I had a life-changing event. Why can't we make this a thing? Why can't we do this for our faculty and students, and et cetera, and make this something that everybody can participate in? And hopefully do some good in parts of the country that are outside of Indianapolis." And so they went on a world tour. They with a small grant from an Indianapolis foundation, and they arrived at 3 finalists, and eventually they landed, come on, clicker. They landed in Africa, and specifically in Kenya, and specifically in the town of Eldoret in western Kenya, which is where there was the second national referral hospital for the country, the main one being here in Nairobi. And they were establishing a new medical school at Moi University, which was located in Eldoret, Daniel Moi being then president of Kenya. And they wanted to be a community-based medical school, and they wanted a partner in doing that. And so our division got involved with that. The model was we'd have a full-time faculty member on the ground to help coordinate exchanges of students, and it was bilateral exchange of students and faculty, not just unidirectional. It wasn't parachuting in, doing some medical tourism and coming back out. It was actually bilateral exchange of students and other people in both directions. This is Eldoret, and it's kind of typical of an East African city. It's constantly being built up and constantly melting at the same time. So a mixture of new and old. And this is the hospital that was already there that became the platform for the medical school there. And for the first 10 years of this collaboration, it was mostly this educational exchange. It happened in the hospital. It happened in outpatient areas. So this is Masoriat. Masoriat is about 25 kilometers, is that right? About 25 kilometers south of Eldoret. And it was because it was closest to the university, it was involved in a lot of training, both in public health and in medicine and nursing, et cetera. And where a lot of innovation took place because it was a little smaller and it was a little isolated, et cetera. Typical cinder block buildings. If you've ever been in a developed country, this is what clinics look like. This one is particularly big. I had nothing to do with that. I had no interest in international health. I don't know that at that point I ever even traveled overseas. I was a computer geek and general internist, and my job was to help take the systems that my mentor Clem McDonald created and get them actually implemented. We didn't call it back then, but I was essentially a CMIO, a Chief Medical Informatics Officer. Because I was a former chief resident, I knew everybody and everything, how things went. I got people to use stuff and then beat on the developers that it's got to be something that physicians find usable. That's a new notion. It initially started with kind of DOS-based things, and in 2013 it went to 25 years later, it went from DOS to a Java-based system, web-based system. And essentially, we studied how people use this on an inpatient environment. And this was a picture of the hospital, of a 103-year-old hospital a year before they tore it down and built a new hospital. But everything that happened within this medical record system, and that's what I did. And then this happened. So I had, again, this is now the late 1990s. I was doing my own informatics and health services research, and the Fogarty International Center at NIH came up with this program called International Training in Medical Informatics. And they wanted to fund 4 sites in sub-Saharan Africa that help train Africans to manage information. And I didn't know about this, but Bob Hunters came to me and said, see this thing, we'd like you to apply for it, because the librarian doesn't have any books in it, and if we can set up a digital library, that would be a good thing. And so I said, okay. And we wrote a grant proposal. We were the only funded informatics training program in the country that actually had a footprint in sub-Saharan Africa, so you might guess it wasn't hard to get funded. And it got funded, and that was in 1997. In 1998, I went to Kenya for the first time, where I met these guys. So these were the 4 fellows that we trained during the program. I'm going to fast forward. He became the dean of the School of Public Health and the principal of, I forget which campus he was part of, but I don't recall. But he became the chairman of the Department of Medicine, I'll get into SECA a little bit later. He became dean of the School of Public Health and inaugural chair of the Department of Medicine at Maseno University. See, I actually keep up on this stuff. And he was also Department Chairman of Medicine as a pulmonologist. So it started out with Joseph Rotich. So Joseph was actually a biostatistician and knew how to program an MS Access. And when I went there, I said, okay, we're going to do all this funky stuff with libraries, and because that's what we said we would do. And they said, that library stuff is fine, but we'd rather build an electronic medical record system. Okay. Because I didn't know anything about libraries, but I knew a little bit about that. And so we went out to Masoriat, and we sat there. And myself and a friend of mine, I couldn't get anybody from my institute to join me because they were so busy in our hospital, and what did we want to get in global health stuff? So I grabbed a friend of mine from Australia, and we went to Masoriat, and we essentially said that was their record system. That was 30 years of records. They keep these sheets that go in these books, these log books. They use them to generate the monthly Ministry of Health reports, and they're never looked at again. If you took these out of there, they'd literally crumble in your hands. So there were no records at this place, which is actually a great way to develop a system because there's no legacy systems you have to deal with. And so we asked the clinicians and the people running the clinic, what do you got to know? What do you want to know? What they got to know is the things that report to the Ministry of Health. So those were the first things that we had to put on some kind of encounter form. And the second thing was, what do you want to know if the patient happens to come back? And because generally you don't know anything when the patients come back because there are no records. They come back with them, and no records that were kept. So we developed this simple patient encounter form for all the clinics, and you can see the different clinics, the child care under 5, antenatal care, pediatric, family planning, adult medicine, and very simple stuff. And it was programmed, that we had a paper form, and then Joseph, and with a colleague from Indiana, programmed a simple MS Access form. Why we use MS Access? It's not a database system. Why would we use that? And he said, because we could. They had local programmers. Again, one of the fundamentals of this was don't build dependency. Build capacity. So MS Access came on all the Windows-based computers that you bought, so it's free. And there were already existing programmers in Sub-Saharan Africa and in El Dorado who could maintain this stuff. So a very simple system like this. And we had created a data dictionary. And if you'll notice here, this was back in 1998. It's ICD-10, so we were ahead of you guys. But just simply, how do you define things in a system? So build a dictionary that's specific to the things that are being used and done there, full of different synonyms, and all these things are synonyms for amoxicillin, et cetera. And then we launched it in February of 2001. And as far as I can tell, it was the first ambulatory electronic medical record system in Sub-Saharan Africa. There were a couple of big hospitals in South Africa that had some kind of information system, but it wasn't this type of thing that served the clinicians. And we used paper encounter forms because, again, we could, and it required the least amount of equipment. Paper is easy, portable, it's easy, and also create a separate paper record because the Kenyans initially couldn't believe that, where is it? Once you're in there, where is the information? It's in the computer. Well, they can't see it in there. So having the paper record actually made them feel good. In the end, when they finally accepted the system, they just handed it to the patient and said, take it home. And this is us standing in front of, there's a goofy picture of me, but it's standing in front, this is 2001, standing in front of that cabinet with these records in it. I couldn't find it on my computer, but I got a picture of that cabinet 10 years later. It's got coffee cups on it. They no longer have any records there. So this system was then used to do various things, but what it did is that it made this the #1 health center in Kenya. Because normally it takes an average health center 2 weeks to get all the logbooks and little tick marks and create this report that then they would mail in or courier in to Nairobi. And here they said, here's the date range, push a button, it generated the reports. So they got the reports in within a day instead of within 2 weeks. But also they were able to say, I won't go back to it, but well, maybe I can. Let's see. If you look here, we captured actually what was paid. And certain things like antenatal care and TB care and stuff is provided free, but the others I was supposed to pay for. And what they were able to show is how much uncompensated care they were providing. And so they got more money. And so because they got more money, they were really happy that they had the first electronic medical record system. And they had the audacity to name me an elder of the Nandi tribe that in the area surrounding El Dorado. So this is me in the ceremony becoming an elder. There's another part of the ceremony that you don't want to see. So, and I'm happy to say the video that this came from with me and Bob dancing with spears and shields, it doesn't exist. It was pretty ugly. But it worked. So now that it worked, the reason why these fellows wanted to use it is they wanted to do research with it. It wasn't just to serve care. It was now generating reports. For example, they saw a series of cases of rabies, and they saw where people came from, and they found the dog, okay? They found a village where people, they knew that the number of vaccinations didn't match the number of people in that village, and they sent a nurse out there to vaccinate people. They now could do stuff with data, population health, that they couldn't do before when they had no information system. But now they can also do research. So Darrell he liked pulmonary medicine. They don't really have specialties in most cases. They don't get trained for it, but he liked pulmonary medicine. And so he created a system looking at acute respiratory illness, just saying, no one really knew what happened to these people. You treat them, they'd come in, urgent visit, they get seen for some kind of breathing problem, be sent out, and you never saw them again. And you never really knew if what you were doing was actually helping. So we created a form. It was a paper form, and this is the computer entry part of that, where it just captured information from the patients at the time of the visit, if it was for an acute respiratory event. And then, as part of this project, He hired a guy on a bicycle who took a random subset of these people and went out to their homes both 7 and 30 days later to say, how you doing? All right? And how you doing was these screens, and yes, that is a Palm Pilot. And just ask things like, you have a sore throat, are you coughing, are you short of breath, are you producing sputum, you having chest pain, do you feel tired, do you have a fever, and did you receive medication for this illness? And can compare that to actually what was prescribed, right? And so Lamech published his system in the Biomed Central Medical Informatics and Decision Making, and so for a little more than 3 years, or a little less than 3 years, he saw a little more than 2,000 patients, almost 3,000 visits for acute respiratory infections. For a random subset of 22% of them, they went out 7 to 30 days later, and they got complete data on 88% of them. And what they showed was about what you'd expect. So half of them had just URIs, about 1 in 6 had pneumonia, asthma, tonsillitis, bronchitis, blah, blah, blah. So it's some pretty typical primary care stuff, right? 7 days later, they were all still pretty symptomatic, and 30 days later, they're still pretty symptomatic. These people had terrible outcomes from this. And I can't say that a lot of changes were made in the clinical system, but it actually surprised them to the degree to which people actually didn't get much better, and how much of that is actually chronic disease rather than acute illness. It turns out that a very common problem, as you might guess in this area, is COPD and women cooking over biomass stoves in poorly ventilated houses. And so a lot of this could be actually COPD and not an acute on chronic pulmonary disease, which did not get better in a month. Next came Wilson O'Darrow. Wilson was interested in trauma, specifically road traffic accidents. And this is a World Health Organization injury surveillance form that he wanted to program into the computer, and he wanted to follow it up because he was convinced if we could identify the places where people were suffering trauma from road traffic accidents, then you could do something. They don't have traffic lights, but put in a speed bump or put in some kind of traffic control device that would prevent those things from happening. So that was his goal, that the major thing they were going to see is road traffic accidents. And so he captured data on 315 consecutive patients over about 9 months. Of those, he had 200, for 91%, he had follow-up on site of injury and at the home by a research assistant on a motorcycle. He geocoded the site of injury and collected follow-up information on those people. He published a couple of papers, one describing the system in Journal of Biomedical Informatics, and this was in the East African Medical Journal. And so what he found was that the so the most common things were being struck by an object, assault, or a fall. And only 4.7% of these people actually had road traffic accidents. So he didn't see what he expected to see because he didn't really systematically look at the data. He just saw what he saw, and we all have biased ways of perceiving things, right? And so, and this just shows the kind of thing, he also had active, what were you doing at the time? Working, some kind of vital activity, play, traveling, and blah, blah, blah. And then he was able to map these things out. So he G-coded it, and this is actually a footpath that goes through here, and this is a little gathering place at the crossroads here, and each one of these black things is an assault. So he's able to identify places that you don't want to be walking there, or places where the police ought to be paying attention to it. But interestingly, he didn't see much on the roads. So he disproved his hypothesis that road traffic accidents is really something worth worrying about. And then, so I'm going to shift gears here a little bit, away from research more to talk about the IU Kenya program. At the time, we're still mostly an educational exchange. We're caring for people in the hospital. Additionally, the university had joined us. Brown, the University of Chicago came and went. Wayne State came and went. Several other universities joined the group, I think a total of 6. And then Joe had been the anchor physician. Remember, I said somebody was there for a year. He was the anchor physician on the ground from 1992 to 93. Then he retired in 2000. And I took his place as the second division chief our division ever had. And he went to Kenya, and he thought, I'm going to be the anchor physician for a couple of years. I'm going to come back, and I'm just going to be a primary care physician and hospitalist in the Wishart system for the rest of my career. What he didn't expect was AIDS. So he arrived on the ground there in 2000 in the height of the AIDS epidemic. And it was devastating to Kenya. The average life expectancy went, over a period of a decade, the average life expectancy went from 68 years to 50 years. Because it mostly affected people in the prime of their life, men and women in their 20s and 30s, and it also affected about 1 out of 7 people infected were children. And I saw something when Joe went back over there that I had never seen, is that Joe got depressed. He's the most pathologically optimistic person I have ever met. And he was depressed because there was no treatment for this. There was no treatment for the super infections you get because of AIDS. There was nothing. He was just watching people die. And said, there's nothing here. We have no way of treating this. Come on, you can do it. And it overwhelmed the system. There were 2 patients to a bed, head to foot, back to back. This is not unusual. Every bed had 2 people in it, and occasionally somebody sleeping underneath the bed. And this was the inevitable result. And this is a great picture because the entire healthcare system, Joe as well, were turning their back on it. This is the only vehicle for the AIDS program in an entire, the Washington County of Kenya at the time. There was no program. There was nothing there. And then Daniel happened. Daniel Ocheng was a medical student, and when Joe came into the hospital one day, he saw a medical student sitting on the side of a bed with a patient in bed, and he said, "What are you doing here?" And he said, "That's my classmate." And that was Daniel. Daniel weighed 70 pounds. He was dying of AIDS. He had cryptococcal meningitis. He had PCP pneumonia. Turned out he had CMV retinitis. He was a mess, and he was dying. He was literally lying at a puddle of his own stool. And Joe looked at him and said, "He's us. How can we not do something?" So he got on the email, which at that time was a 2400 baud dial-up modem, and said, "We're going to treat this kid for AIDS. These are the things I think he has. Send us the drugs for the next person to come on over." And 2 days later, they arrived. And they nursed Daniel back to health. I mean, he was in the hospital for several months, but in a week or so later, Daniel woke up. And the first thing he said was, "Kill me. I can't live with this shame." And Joe said, "No, not going to do that." And so when Daniel was ready to go home, they went to discharge him. They couldn't discharge him. And they couldn't discharge him because the medical school hospital wouldn't take him back in because he had AIDS. They tried to put him in a hotel in town. The hotels found out he had AIDS. They wouldn't take him. So Joe did what Joe did. Joe adopted him, and he moved into the IU house. And then Daniel started doing something that is more remarkable than you can possibly understand. He started lecturing students about AIDS. At that point in time, there's nothing more embarrassing you could do to say you had AIDS. If you were a woman in the rural areas, you'd be killed or be kicked out of your community. You'd lose your house, you'd lose your kids. You just don't do it. And he started saying, "I visited a prostitute, I got AIDS, don't do what I did, here's how you protect yourself." Remarkable thing. And then Joe said, "If we can treat Daniel, why can't we treat other people?" So Joe came back to Indianapolis and started lecturing at churches, saying, "We want to launch an AIDS program. It costs $2,000 a year. It costs $1,000 a year to treat a patient. If you give me $2,000, I'll treat one patient for 2 years." And he got several tens of thousands of dollars and went back over and opened up a clinic in Eldoret and one at Mosoriot. And launched this thing called AMPATH. And at the time, it was called the Academic Model for Prevention and Treatment of HIV and AIDS. And the idea was to, leverage the tripartite academic missions of service, teaching, and research, but you lead with care. Everything's focusing on, you do care first, and the other things to support care. Yes, you use the care environment to support teaching and research, but everything comes down to making a difference in care, and bolstered by the teaching, training, and research environment. And build local capacity and infrastructure. In other words, don't build dependency, build people who can manage their own problems. We had to train everybody. Nobody knew how to do this. Joe didn't know how to do this because in Indiana, HIV was such an uncommon disease that everybody was treated by an infectious disease specialist. So we had to train ourselves in how to manage HIV. You had to get the community on board. And this is a very stigmatizing disease, and community health centers, they had to be on board. We even had to get traditional birth attendants on board. This is kind of the outside the traditional medicine, outside conventional medicine, more traditional medicine, and they train these people to do HIV testing in people's homes. And if somebody tested positive, they would escort them into one of the clinics to get treated. And then Joe sat me down. I remember they very explicit early on in 2001, sat me down and said, you know that cute little primary care information system you have out there? Well, sit down because we're going to create an AIDS information system, and it's going to be, because there's a lot of information we have to capture, and there are a lot of people in our catchment area, maybe as many as 1 million, whom we're going to be treating. And so we developed, at that day, encounter forms for HIV and AIDS, which we vetted with the clinicians and captured information, a core set of data on every single visit of every single patient. This is the return visit form for adults. And this looks really crowded and stuff, but this is the way Kenyans liked it. You know, this would drive me crazy. It took 1 to 2 minutes to record information for a visit. No pajama time in Kenya, if you know what that means. You know, never mind, you don't want to know. People hate their EHR so badly here that they don't do this stuff at work. They get home at night, and after the kids are in bed, they go and write all their notes. That's called pajama time. It wasn't necessary in Kenya. So everything that was done on these paper encounter forms. And why are we using paper encounter forms? Why didn't we use things like scannable forms and things like that? We costed that out. It saved no money over hiring Kenyans. So why would we use scannable form when we could hire Kenyans? So in our pharmacy and primary care, it was all based on these forms, which were then entered into a system, and then could generate things like this. This is a summary report that was printed off before somebody came in for a visit. The top part showed, identified the patient, showed the past history, current drug treatment, et cetera, and any drugs, that's drugs prescribed on the last visit, et cetera, and current OI is opportunistic infection to being treated with clotrimazole. The middle part of it has a flow sheet of recent data, and the bottom part of it were computer reminders. And this actually worked. One of our colleagues published himself showing this actually improved adherence to guidelines for care in a very busy clinic. And so these data were entered into a system, and it all worked because of Erica Kagotho. And if any of you know her, she's a force of nature. She's one of the most powerful people I have ever met. And the success we had in electronic medical records had very little to do with me and everything to do with Erica. But these are the people entering data in the system and generating reports from it, et cetera. And then, currently we've actually switched to using tablet computers because they're now cheap. We actually have the technology to be able to hook them up through Wi-Fi to the central repository, which was not available when we started this 15 years ago. And the program grew. So initially in Eldoret and Masoria, but spread all the way throughout Western Kenya, and that's area here. And this is probably 150 kilometers across, give you an idea how big it is. And we got our first funding. We wrote a grant in 2001 for initial PEPFAR funding and got $1.5 million. And the first round of major funding was in 2004, and we got $15 million. And from then until 2017 or 18, they've got $125 million of funding from the Presidential Emergency Plan for AIDS relief. By 2007, they had enrolled 70,000 people, of whom about 50,000 were actively on treatment. Other people have moved away or died or something like that. What they found was when they first started treating HIV, people died anyway, because they came in near death, starving to death. More often women than men, because the men didn't get treated, they died. They infected their wives. The women came in having given all their food to their kids because they didn't have any income because their husband was dead. And they died anyway despite giving them antiretroviral drugs and antibiotics. And so Joe, with other people, and actually an NGO out of New Zealand, started generating these training farms to train these subsistence farmers how to grow crops in very very effective ways on very small quarter-acre plots of land. Even doing things like this to irrigate, because Kenya tends to be wet when it's wet and really dry when it's not. And they did such a good job that they grew more food than they could eat. And so they developed a cooperative among the different farmers so they could start selling it back. And now they've got some economic generation, because the real problem here is poverty. Right? That's generating all of HIV/AIDS risk, is because people leave their home in rural Kenya to go to one of 6 cities for a job, and they're without their family, and they're visiting prostitutes or doing other high-risky things, drinking, et cetera. If they were in their home, those things might not happen, but there was not enough economic development for that. So this helps get past that. And so, but that wasn't enough, because now it's 70,000 people. You can't feed all those from a farm like that. So we actually applied for and got major funding from the World Food Program, and we're at the height of this feeding 30,000 people a week. And it's every person who came in as a new patient would see a nutritionist and get a nutrition prescription filled out. That prescription would then get entered into a computer system, which would then generate a whole series of things that allow us to essentially a chain management program, going all the way from putting food baskets together, delivering them to the health centers, and then reconstituting those for people who didn't pick them up for other people, et cetera. It was complex, but it was managed by an information system as part of our overall medical record. But that wasn't enough, because the problem was poverty. And so they developed this thing called the Family Preservation Initiative, which included things like clothing factory. So this is the clothing factory. There's the Amani Workshop, which is kind of arts and crafts that if some of you have been there, actually fairly nice stuff that gets sold pretty widely. A number of other things that generate economic activity. And then they launched these things called the Group Integrated Savings and Empowerment, GISI program. And this was just allowing people to take control of their own lives. And so they started out with a group of just 25 Kenyans who would meet once a week, and they had to put at least 100 shillings into the pot, with their name. So that was all, you can see that there are actually ledgers sitting here, and there's the lockbox. And you had to put at least 100 shillings in. And then if you'd been participating for, was it a year or something like that, you could then take a low-interest loan out. And they started launching businesses from this, and then they'd get paid back, and that money would get lent to somebody else. And they started doing a lot of economic development. This idea caught on so much, there are now 5,000 of these in Western Kenya. 5,000 times 25. So that's the number of people doing this. And they said, we don't want to get the banks involved, et cetera. They've had to, because they've actually collected millions of dollars. A shilling is $1, essentially. I'm sorry, 100 shillings is $1. A shilling is about equal to a penny these days. And then they got smart and said, well, why don't we use that to enhance care? So if you had hypertension and your blood pressure was down, they put an extra 100 shillings in the pot. A lousy buck, right? Doesn't sound a lot to you, but that's about 130 shillings was the average daily wage there. If your glycated hemoglobin had dropped, I don't know what the threshold was, they put an extra buck in there. And what they showed is, you probably can't read it, but it says that it actually lowered the blood pressure compared to a control group significantly, while generating economic activity. So in 2007, I showed you that curve at 2007, we got some money from a foundation. Tim Evans? Clay, ever heard of Tim Evans? So Tim Evans, he long story, but he's now working for WHO, and he worked for the foundation that originally funded us. His family's foundation gave us several $100,000 to assess what we're doing with AMPATH. And so they met with the providers, they met with patients, and they had these things called barazas, which are community gatherings where they could interact with the community and just say, what do you think about what they're doing? And what they said was, we really like what you're doing for HIV and AIDS. It ain't the only problem we got here, and it's not even the worst problem we got. There are more people who die in Western Kenya of cancer than AIDS, TB, and malaria combined. And they said, you're actually sucking the life out of the rest of our health system, because you pay more reliably, people want to work for you, et cetera, and you're actually hurting the rest of our care. Care for us, don't just care for AIDS. So they took that to heart, And they renamed AMPATH to what you heard earlier from Alexia, the academic model providing access to health care. And instead of focusing just on HIV/AIDS, they focused on non-communicable diseases and opened subspecialty clinics initially in these areas, for which, you know, they came to me and said, we need encounter forms and we need to enter these data, et cetera. And they actually, the PEPFAR program gave funding to expand in more counties in Western Kenya. And more sites. There's something like 500 sites that they're in right now, and caring for more than 800,000 patients. The 2007 was when they decided to ramp up these clinics. It took a couple of years to get it started. 100,000 patients with HIV and AIDS, the largest AIDS treatment program in the world. And here's the growth, mostly with NCDs. At about 2012 or so was the informatics core. These are the people who run the information system there. And if you look, there are 2 Wazungu, right? 2. Everybody else was Kenyan, and they were advisors. They didn't run things. Erica ran things with an iron fist, and always with a smile. But everybody had to be trained there. There was nobody came in knowing how to do this. Nobody came in knowing how to do anything. At the height, AMPATH had 3,800 people working for it. It's the largest employer in Western Kenya, and had brought in $125 million of funding from PEPFAR. So what about research? And this is about research. That's the platform. You lead with care, that's care. So why do we need research? We need research because no one knew how to do this. All the models of care for HIV and AIDS were generated in the United States and Western Europe. They said you get a viral load every 6 months. A viral load costs more than a year's worth of drugs in Kenya. So they didn't get viral loads, and you had completely new models of care. And we were told you couldn't do it. They can't take the medications on time, and, you know, blah, blah, blah. And we had to prove that it was possible. And then we had to come across, so what's the timing? When do you, and people contracted with TB, do you treat the HIV first, in which case you get the autoimmune reconstitution syndrome, or do you treat the TB first? And those are all things we had to answer. We had to learn about HIV/AIDS and its treatment outcomes and describe and assess programs to overcome social barriers to health. So we didn't just study the clinical care, had to study all these other things that were impacting health. So we need to develop basic infrastructure. So they asked me, would you develop the research program? And so I actually quit my job as division chief of general medicine and took this on. And these are things you had to do. We needed a research office both in Indianapolis and in Eldoret. Which means we need to have a co-director on the Kenyan side and a program manager on both sides. We need to have an NIH certified research and sponsored programs office to manage the money. You imagine, you know, starting from nothing and managing more than $100 million worth of grants and being able to follow every nickel. Certifying IRB and the federal-wide assurance. NIH certified reference laboratory, practice-based research network for recruitment and follow-up, research training for faculty and staff. None of this existed for research and had to be built from scratch. And we had to get complex because there's a lot to do. So we developed research working groups. There were 9 of them in adult medicine, public health and primary care, reproductive health, pediatrics, oncology, behavioral social science, basic science, tuberculosis, and prevention of mother and child's transmission of HIV. We also had co-field director of research. We gave a small amount of funding, 10 or 20% of their salary, to actually shepherd studies on the ground because most of the investigators lived in the United States or Canada, but wanted to run projects in Kenya. You can't do that with either living there full time, which most people can't do, or having somebody be your agent on the ground. But we also needed infrastructure, so operations, data management, biostatistics, clinical informatics, pharmacy, laboratory, and bioethics. And in each one of these things, you'll notice that there is this is Darrell and Tom Manui from Indiana, there is a co-leader on both the Kenyan and North American side, and allowed me to help develop leadership, both relatively junior Americans, although Tom is very senior, relatively junior Americans and Kenyans who hadn't really done a lot of research in their careers. And these are the universities that kind of sought us out. I was having people call me every week saying, I got a $2 million grant, and we're going to do this in Africa, and I would like to do it at your site, and I would tell them to go take a hike. So we don't do parachute research. If you told me that you're just what we're doing, and you want to get involved, and you want to go there and see what the opportunities are, bring it on. but you're not coming in just using us as a research platform. These people actually did bring it on. So all of these organizations had active investigators at one time when I made this slide up in about 2009. And because of our AIDS epidemiology network, I'll talk about in a second, we had other universities in East Africa involved. Managing this by conference calls was a nightmare, but it had to be done. Actually, we had better video conferencing there than we have in our buildings now, but I'll talk with Clay about that in a little bit. This is the original grant for the Fogarty program, and this is when we started the research program. We got our first grant in 2005, and from then until this is 2017, $112 million of extramural funding, and it's now over $120 million in extramural funding. And interestingly, 72% of it is NIH funding, which comes with full indirects, except, and I'm going to editorialize here, if you're an international research site, you get 8%, which means they are actually funding our research over there because you can't do it for 8%. These are the publications, the 620 publications, and this is 2018, the biggest year, so over 141 publications, and now just about 50% of the first authors are Kenyan. I'm going to give you a couple examples. So this is an early paper from 2006, and it just says, we can do this, because people didn't believe you could do this. So it says down here, antiretroviral treatment of adult Kenyans in this cohort resulted in significant and persistent clinical and immunologic benefit. The findings document the viability and effectiveness of large-scale HIV treatment initiatives and resource-limited settings. The cost for treating a patient for HIV, we got free drug from PEPFAR. The other costs are less than $200 a year a patient. This was a randomized controlled trial of community health workers delivering care at home as opposed to patients having to come in once a month to the clinic. And what they showed here was through this task shifting of care to, and these were not just community health workers, these were our patients. Each one of them was HIV infected and was taking medication. And it says essentially that they resulted in similar clinical outcomes in usual care with half the number of clinic visits. It doubles the capacity of a health center, which was a limiting factor in our being able to ramp this stuff up. We were part of a number of research networks, which included IDEA, the Merck Vaccine Network, AIDS Clinical Trials Group. It was the #1 international clinical research site in the world at the time as far as the number of people enrolled in protocols. Global Network for Women and Child's Health Research and a global network from NHLBI. Our information system went from MS Access to a real information system and is now called OpenMRS, has been implemented in all these countries, and is a national medical records system in all these countries. In Kenya, Tanzania, Rwanda, Uganda, Nigeria, Mozambique, Bangladesh, and the Philippines. We capture a bunch of information. This is mostly the clinical forms, but there are forms here for nutrition, food distribution, social work, orphans and vulnerable children program, federal preservation initiative, and these are getting into some of the other socioeconomic and some of the other clinics that we had to open. But you can't treat AIDS into oblivion because you're asymptomatic for 10 years before and contagious before you develop symptoms and get treated. So we decided we had to go upstream and do home-based counseling and testing. And the idea, since the stigmatizing, people weren't coming to get tested, we had to go to them. We approached them by barrages and getting community leaders involved, et cetera, and did a household census, health needs assessment, HIV/AIDS testing, pregnancy testing, blood pressure and blood sugar testing. And again, launching it first by getting community involvement, and went to the sites of care, captured information. I'm not going to go all these things. The slides are going to be available, but these are the information created about the household, about the occupation. If people wanted to get enrolled in the system, we could enroll in the system and give them a medical record number so they could take this to the clinic and be seen and have these data linked to that. We captured some information about clinical conditions, and then we tested for HIV. And whether or not they were discordant, TB, and it sounded like they had TB. And so this started in about 2009. By 2014, they had knocked on the doors of 1 million people and had gotten 98% complete capture of information. By last year, it was 2 million. And this is the first 150,000, and just briefly, only a third had been tested for HIV, and 4% were previously known to be infected. Almost everybody was counseled. Almost everybody was tested. 3.7% of patients were found to be newly infected with HIV, and overall prevalence was 7.5% in this population. 11% they called older adults, which is there is 25 and older. So that's not insignificant. They found more than 70,000 people previously undiagnosed with HIV and referred them into care. I'd like to say they all got into care. It was a lot harder than that. 20% of the patients had a systolic blood pressure over 160, and 10% of them had a glycated hemoglobin over 8. So what about Austin then? So what can we learn from this? Well, we've got this thing called the Neighborhood Health Initiative that begins with, which is the idea of a federal qualified health center is an anchor institution for health in the neighborhood in which it exists. It starts with a focus on both clinical care and social barriers to health, and it begins with household level assessments, home-based counseling and testing, right? And here, culturally appropriate community health workers going to door, referrals, social needs where necessary, referrals to medical care to the FQHC, and task shifting of income here where feasible. As we launch this, they can follow up on blood pressures and blood sugars in the home. They don't have to come into clinic for that. And this is a feasibility study that we recently completed in town here. We did 100 households, and one in Runberg where 91% were Latino, Hispanic, and 79% identify themselves as immigrants, as opposed to South Austin, which was much more mixed. 15 to 20% had no medical care. Less than half were getting primary care and prevention, or primary care for a medical problem. A lot of urgent care in South Austin, not much in North Austin. A lot of hospital admits in North Austin. So there are a lot of health care needs that aren't being met, but also health needs. So you show that 24% of people had trouble paying their mortgage, 23% threatened shut-off utilities, and I shout out to Alex Garcia, who led this project. We're sitting in the second row. Raise your hand here. Yeah. So popular health research. So what can we add to this in a research mission here? The first thing is, what are the outcomes and costs of new models of primary care that are community-based? What other types of community-based participatory research can we do? Can we launch place-based calls for ideas from the community for making the community more healthy? And we're developing an information base that's going to be a healthcare information change that will have both social drivers of health and clinical drivers of health. And these are some of the things that we're going to be adding to the system. So briefly, so what have we learned from this? So we're just about done. So what have we learned from this? One is be audacious, all right? If you aim small, you hit small. So be audacious. But it's going to make you nervous. And if you're not nervous, you're not trying hard enough. Anxious is sometimes can mean two things. Anxious means you're nervous, and anxious means you're excited, right? And the answer is yes. But you should have a level of anxiety about what you're doing, or you're not trying hard enough. If it's the right thing to do, commit. Say it's the right thing to do, we're going to do it. Then you say, how am I going to do that? Then figure it out. I learned that from Joe. Think big, but start small. This is implementation science. Best evidence, start small, capture all the information you can, measure, and then don't get really, enhanced in love of something because it could go away. Our farm is no longer there. It was a big feature of stuff that's no longer there. The World Food Program is no longer there. We replaced it with Geesey. They're buying on their own food. Start now, and with best practices and available evidence, assess early and often, be willing to change everything, and information is key. Measure what matters and act on what you're measuring. And it takes passionate, energetic, multidisciplinary team. You can't do this alone. Nobody can do this alone. Listen to those you serve and to those serving them. Population level interventions require household level data. Start with those who are most in need and marginalized and ignored. Don't introduce and study, and this is I get from Clay too, don't introduce or study something that you don't plan to continue if it's successful. We don't do parallel research. We go in, study something, and if it works, then we find some way of making it happen. Stay optimistic, because this gets hard at times. And if it's not hard, you're not trying hard enough. One person can make the difference. Remember Joe and Daniel. Remember Bob. Seek and develop leaders, human capital, and infrastructure, and we can do this. And we're doing it. It's been done in Africa. We're going to do it in Mexico. We're going to do it in Austin. In the end, it's all about families, right? I mean, this is all, people are people all over the world. I learned that a lot, which I didn't know before doing this, is that they all have children. They're all lovely people. We got to give them a future. Because the world is watching what we do. And we ought to take that on. I actually took this picture, and I was actually pretty close. The world, bring it on. We should expect to be held our feet to the fire to do important things. Because if we don't do it, who's going to do it? If we don't care for the people we're serving, who's going to care for them more than us? And we have to bring whatever talents we can to it. These are turbulent times. Okay, this is a tornado coming towards my house in Indiana. You know, so these are turbulent times that we're in. But I think that the sun is rising on the things that we're doing, and I think that we all can participate in something that is, despite that there's been some successes, we can pick a place where it's new and see what can we steal from other places and do something good in the world. And I want to say that I'm honored to give this lecture in the honor, celebrating Dr. Gallman's career, and it's been a pleasure. Thank you. Oh, thanks. Oh, here. All geeks have Diet Cokes.
Thank you, Bill, so much. Can everybody hear me okay? All right. My name's Tim Mercer. I'm the Director of Global Health and faculty member in the Department of Population Health at Dell Medical School. And I just want to thank Bill again for giving this lecture. Thank you very much to the School of Nursing for hosting the LaVerne Gallman Distinguished Lectureship. And thank you all for coming very much. We really appreciate it. I want to take this opportunity to introduce our guests. We have with us Professor Dina Chelagat and Professor Lukoya Atwoli, the deans of Moi University School of Nursing and School of Medicine in Eldoret, Kenya. Dr. Chelagat currently serves as the second dean of Moi University School of Nursing. She received her nursing degree in Kenya and then went on to get a master's degree in family planning in the UK and another master's in public health from the University of Alabama at Birmingham. She then pursued her PhD in nurse midwifery from the University of the Free State in South Africa and is an active researcher and scholar in maternal child health and the relationship between spirituality and health. And so welcome, Dr. Chelagat, Dean of Moi University School of Medicine. Professor Atwoli is the fifth dean of Moi University School of Medicine. He graduated from Moi University and was among the first class of students, actually a classmate of Daniel's, and when he was a student did his student exchange at Indiana University as part of the AMPATH program. He then went on to pursue a psychiatry residency at the University of Nairobi and a PhD at the University of Cape Town in South Africa. He's a practicing psychiatrist at Moi Teaching and Referral Hospital, the second largest tertiary academic medical center in Kenya. He's also an active researcher, a visiting scholar at Harvard School of Public Health, and a researcher on the health effects of trauma and the genetics of psychiatric illness. He's a thought leader in Kenya, serving as the vice president of Kenya's Medical Association, and in his spare time for the last decade writes a weekly social and political commentary column in The Nation, Kenya's largest national newspaper with a readership of about 5 million. But if you know Kenya, everyone in that country reads the newspaper. So I think he finished his weekly column just this morning between meetings. So welcome, Dr. Atwoli. I'm going to jump up to that mic there, and I'll walk around, but we'd like to open it up for questions for Dr. Atwoli, Chelagat, and Tierney.
Well, while we're getting started, I actually have a question for you too, and that is that, you've seen the story of building the research infrastructure. What's next? What are the things on your horizon, both with a relatively new school of nursing and a maturing school of medicine? What's next? What are on your horizons?
Good evening, all. Yes, the horizon is far to reach. In the School of Nursing, we are just about 7 years old. We are trying to build the capacity of researchers so that we can go back to the community, having done what has been reported heavily by Bill. We want to see how we can do more preventive, especially now. Our country is working on universal health coverage, so we want to see what are those things that would facilitate the population to get the care that they need or to prevent those diseases. So we are working together in the counties because health is being devolved to the county governments. So although we have policy coming from the national level, each county is working specifically to see what are the priority areas. And therefore we are engaging, and how we engage as a school is we use our way of learning, which is community-based, where we send students to the community, where they do the community entry, just the way it was reported that before you get to the community, you must win the confidence of the leaders, and therefore we do community entry, then we do community diagnosis, and then be able to report to the community what we see is a problem and how best we could be able to work together to overcome. So that is what we are doing now in using the universal health coverage, which is, it has been very hard for people to get the care because of the cost. So the country has even rolled out the NHIF to be able to assist people access care because cost is a major problem. Thank you.
Yeah, good evening. Yeah. Thank you very much. The School of Medicine, as Bill correctly says, is maturing. We've been around for 30 years. That's a relatively small time to be for a School of Medicine, even in Africa. The University of Nairobi is almost twice that age. So just like the program in AMPATH has matured and developed, so is the School of Medicine. The story that has been told this evening is the story of the School of Medicine. We have moved away from the earlier focus of sorting out basic problems like infectious disease, like HIV, and we are now looking at population health. So we are launching, and we have in the recent past launched an initiative to look at population health, and that does not only look at the disease model, but looks at health holistically with nutrition, environmental health, sanitation, and so on, as well as screening, leveraging on what we have learned from the HIV intervention to start addressing chronic disease like mental illness, cancer, diabetes, and so on. And in order to achieve this, beyond care, going towards training, we are pivoting away from being a mass producer of doctors and basic level healthcare, and are now developing the infrastructure to do more residency training, more specialized training, and more postgraduate, training, PhD level, and so on, in order to prepare the next generation of specialists who will do mentorship for the lower level health workers, but also continue generating the evidence that then feeds into policy and feeds into care in the country. At the moment, we are recognized as a leading influencer of policy, initially with HIV/AIDS, and now with chronic disease, and even more with health financing, because that is a big conversation. I notice you're having the same conversation in the US, and we are having this conversation as well on health financing. And we were ahead of the conversation because we are piloting a health financing solution in the community that is generating some interest in the county leadership in our catchment area. And we hope to use that evidence to inform the conversations on universal health coverage and hopefully influence national government policy on what kind of health financing would work for a population such as ours.
Clay.
Yeah, so I have a question for you. Also, you know, from such an old medical school at 30 years and an older nursing school at 7 years, right? So we're a brand new school, we're just 5 years old. Yeah. You have a lot to teach us. So one of the things I want to talk about is, or let you talk about, is how you work together, how you think of the team, how you work interprofessionally, how you educate, how you round, how you care for people out in the community, yeah. In the sort of the interprofessionalism. We talk a lot about that here, but you have more experience in doing this, and yeah. The way that you think about resources has guided you to different kinds of encounters. So if you could talk a little.
Can everybody hear Clay's question? Okay, I couldn't tell it was on. Okay.
All right. So what I think an indispensable ingredient of what I would think of as a successful health training program is visionary leadership. And I think I see that here. So, and I'm not only saying that because I'm here, but I see visionary leadership because you have to think about these problems at the beginning. You cannot afford to start thinking about them after you've been running for 10, 15 years because then habits are fixed. And this is something that we were lucky to have at the beginning. So the founding dean of the school knew and insisted that every program that we established had to have multidisciplinary contribution. And so our MD program, the curriculum is a British model, so it's MBCHB and it's a 6-year program. But it has a huge component that is contributed by people from other schools, from the School of Nursing, from the School of Public Health, from School of Dentistry, and so on. So right from the first year, the classes that the students attend, we have tutorials, small group tutorials, and in those groups have students from the various programs tackling the same problem from their different perspectives. And this continues for 2 years. The first 2 years of their training, they do almost more than half of the training together in the tutorial groups. And the second place where they get to interact even more intimately is in the community-based exposure. They are sent off to community health centers such as the one that was projected here. And they stay 1.5 to 2 months as a group of 8 to 12 students from different programs, tackling, first of all, doing a community diagnosis to understand the health problems of the community from different perspectives, and generating solutions from different perspectives, but in one report. So they have to work together to produce a report that says that these are the health problems in the community, and these are the solutions we propose. And at the same time, they help out at the health center, and they help out in the community with the water sources, cleanliness, and so on and so forth. So the idea of working in a large team of various professionals is instilled in the students right from the first day they step into the medical school or in the nursing school or in any schools in the College of Health Sciences. And in all the programs, this is built in so that our philosophy is that we're training you in the environment in which you will eventually practice. And this environment will be multidisciplinary whether we like it or not. And so we train you in a multidisciplinary environment. And staff from the School of Nursing have classes in the School of Medicine. And we have classes in all the schools in the college. And you have to begin at the beginning. Because what we learned is that, so after we were successful, other medical schools, like the University of Nairobi, has attempted to adopt the same system. But it is difficult because the University of Nairobi has been around for more than 50 years. And the medical school is going to be 51 years this year. And it is difficult to bring change. It's difficult to tell an old professor of physiology that he's not the only expert in physiology. and that there are other people who can also contribute to that training. So this is something that has to be thought out at the beginning and built into all the curricula. And the students have to understand right from the beginning that this is the kind of environment they'll be working in, rather than that you have a choice whether to work in this environment or not. If you're going to work on the population's health, you must be ready to work with other people.
I think to add on what my colleague has said is, even in the curriculum development, we work together. Even when we are developing a nursing curriculum, we bring in the basic scientists. Whoever has an input is part and parcel of the team. Secondly, when the students go to the community, for those 6 weeks, each week they are with a member of staff, so they could be with a medical doctor this week, next week there is a nurse, the following week environmental scientists. So there is not only students who are multidisciplinary, but even the staff or faculty who are supervising the students in the field. Yes.
I think we have a question from the audience here.
Thanks, Tim. Hi, I'm Abna Osewasari. I'm associate professor in the history department and also courtesy appointment in Pop Health. Thank you, Bill, for a very interesting presentation. I was glad to see at least one of my students is here, so extra credit for you. So I'm a historian of medicine by training. I work in Africa. I work on pharmaceuticals. And your talk was absolutely fascinating to me for a number of reasons. I'll just look at one aspect, and that's the question of timing and the relationship between empath and the medical school, the School of Nursing, correct, with government institutions in Kenya. So I'd like to know a little bit about exactly when did the first iteration of empath get started, when you started going in and setting up the systems that would allow for the information to be collected, to sort of realize what the health problems were, and the decision to focus on HIV/AIDS because it was this emerging crisis. Because I think especially for students in the audience, it's important to understand kind of, yes, there were individuals on the ground in Western Kenya who implemented this really key project, but it's part of a larger continent-wide struggle that there were national institutions. I was curious to know, 1999 is the National AIDS Control Commission is established in Kenya. What was the relationship between empath and the NACC? What's the relationship with international organizations? Sort of a little bit of a broader picture of how this is situated within the HIV/AIDS crisis in Kenya. And I do have to say, as someone who sits back and sort of observes and watches things, I'm totally fascinated by this activist impulse to get things done. And particularly the informatics side, which we often don't hear about, like how much data really has to be collected to make an impact and make an intervention. So my question was about the history, kind of the timing of when you decide to go in and set up these programs, and the relationship with national bodies besides sort of Ministry of Health.
So it was reactive. It wasn't there's an AIDS crisis, we're going to do something. No, it was a reaction to Daniel. And the person who observed that happened to be Joe, who was a health systems builder. And a health systems builder is not somebody who actually built stuff. He envisioned stuff, and he collected a bunch of people like me in his slipstream just to say, okay, this is what I've committed to, figure out how to do it. And then we would get it done. So there wasn't a lot of upfront thought. It was reacting to, we've got a crisis here, we're going to deal with it, we're going to start small and get bigger. We did actually meet with the NACC to make, because there weren't any protocols. So what are the protocols? And can we develop these not in isolation, but in concert with the other kind of emerging care providers, although it was mostly NGOs at the time. The Ministry of Health had no treatment programs at the time. So we actually did this mostly under the Ministry of Health radar, which actually got us in trouble as it got bigger. They said, what the hell are you doing there? And then we're kind of doing this thing. So we had to ask for forgiveness rather than permission. But we did go to the National AIDS Control Program, both in Kenya, and then when I went and implemented Open MRS, our information system in Tanzania and Uganda, the first place we stopped was there, just saying, we've got a tool for actually approaching this thing, and now that there's more talk about it, let's do it. But there wasn't even any talk about treating it back in 2001. It was when the money started flowing from the PEPFAR program that all of a sudden people started reacting to that. We had previously already begun building the system, not just a provider here and there, but a system that was based on information, based on infrastructure. We raised $50,000 to completely build an AIDS building next to Mesoria because there wasn't enough space in it. So, I mean, we just had to, by brute force, get it started. And then we had, by measuring things, we had examples of how this thing was scalable, and there were tools for doing that. Our information system actually got picked up by the CDC, and they created a boiled down version called Open MRS MD, or minimum data, which allowed people to just take off shelf, turn on, and it would generate all the reports for the PEPFAR program, but wouldn't do much else. So it was a little bit scattered, but it was based on a fundamental system of care within Kenya that added a nutrition program, orphan vulnerable children's program, and a federal family preservation initiative program that were latched onto it, but initially just focused on the crisis of people dying in front of us, dozens by the week of HIV and AIDS. So I'd like to say it was all kind of well thought of beforehand. It was actually kind of scrambling while trying to think system think at the same time, and while delivering care, a small number of providers delivering care as hard as they could with the tools that we had at the time.
Just to add on that, in '99 I was in medical school, and we were rounding on those patients, and the reigning philosophy about HIV was prevention, and everything was about prevention. And I remember sitting with some of my colleagues and asking, because the testing program was just being ramped up so that we know the status. And I was asking some of my teachers, why are we testing them? Why should I do a test and then that's it? Because we would test and find out that somebody is HIV positive, and then that's it. And the public information was, don't get HIV. But now, when you have it, so what do we do? And there wasn't anything until we demonstrated that you could treat people, and if you test them, and the message is that if you are HIV positive, then you may get treatment. Treatment is available. Then that increases the uptake of testing, and that improves outcomes. So this was a problem at the time, and a solution was needed. And the usual solution when you go to the ministry and say, we need to think about treatment, the usual answer is the same answer any bureaucrat will give you when you come with a new idea. It is too expensive. We can't afford it. It can't be done. And so the demonstration was that it can be done. And here is somebody who has been treated, and it hasn't bankrupted the institution. We are still running, and he's alive, and he's useful. And that became the nucleus around which a treatment program could be built. So it was really, the word we use is serendipity. The fact that some people were in the right place at the right time, and Daniel was in the wrong place at the wrong time. And that synergy, that coming together resulted in the development of a huge program that has influenced treatment and thinking about HIV as a chronic disease rather than a death sentence.
By the way, Daniel's still alive and runs the follow-up program. Although he's almost blind from his CMV retinitis. Interesting kid.
So, one more question over here.
Hi, I'm Gary Mueller. I'm an endocrinologist. Thanks for the fabulous work you're doing there. It's truly astounding. One of the problems that we have in the good old USA with medical informatics systems is they don't talk to each other. And if somebody is admitted at Indiana University in Indianapolis, we ought to be able to get their record down here in Austin if we need it. But the systems don't talk. What's being done in Kenya to develop an informatics system where a patient seen in one area of the country, their stuff can be pulled up across the country if need be, so that you have unity of systems with respect to information management? So
several years ago, actually, I think 3 years ago, the government of Kenya decided it wanted to pick a national medical record platform, and it considered several, and it picked OpenMRS and started implementing it in all of its Ministry of Health sites. That's done now. They're now implementing a program called Open HIE, Open Health Information Exchange. All of this is under the owned by a nonprofit company called OpenMRS Inc., for which until a year ago I was the chairman of its board of directors. And through OpenHIE can develop a national medical record that's available. If you go to one of these health centers that are connected through Wi-Fi to all the other health centers, you can access the OpenHIE. It's just now being implemented there. It's actually been implemented in Rwanda. And they just had the first OpenHIE international conference about 8 months ago in Rwanda and demonstrating this national platform. So the fact that it's easier to do there than here is because you started with nothing. And they can say, we're going to buy a system. This is actually a free system. We're building, Kenya established an Institute of Medical Informatics to train people to be able to implement this and deal with it. And as you saw in the picture, they're all Kenyans now. So that's being done there. It's harder here because there are all these legacy systems. They don't talk to each other. Standards and operability is getting better. In Indiana, 117 of the 125 hospitals are all connected to one Uber EHR system, and you can get data across any hospital system. When I came here, I had to print out 200 pages of my medical record and put them on my doctor's desk, and she took it and threw it in the wastebasket. I said, I can't deal with that. Fill out the form, right? So the technology is there. It's not a technology program. Medical informatics is a sociological science. It's a social science. And it's just a matter of trust between these systems and wanting to implement solutions that already exist. It's happening, and we get into it if you want to, but we're actually building a core of what's going to be a Central Texas Health Information Exchange for at least the 2.5 million people in Central Texas. But we could do it the whole country if we wanted to. It's just that there's no impetus to do it yet. The best system for that's the VA, the 157 medical centers across the entire country where the information is available between all of them because they have one central electronic medical record, which they're now replacing with Cerner, so go figure.
About 30% of the American population moving every year.
Yeah.
We sure need it.
Yeah, and there's no question. Your information should follow you where you go. I won't disagree.
So I'm getting multiple signals that we're running short on time, but I'm going to take one last question here, and then we're going to have time for informal conversation and networking at the end. So,
thank you. Thank you. I'm Lynn Rue. I'm a professor here in the School of Nursing, and I just want to start by making a couple of observations. Thank you so much for that interesting display of slides that you provided for us. That was all very interesting. I thought it was interesting also, though, that there seemed to be a great lack of any acknowledgement of nursing in what you did. And yet this exchange that we're having today is being sponsored primarily, I think, by a nurse who was very important to many of us and to many of our students who come after Gallman. I think it's interesting also to observe that the nursing school that you're talking about here is much, much younger than the medical school. And yet I think that as a group of healthcare providers, nurses have been around a lot longer. And so I just want to make those observations. I know you gave credit to our own very wonderful nurse, Dr. Alexa, I'm sorry. I always get Alexa and Alex mixed up, and Steifbergen and Stans mixed up. But you know, I've got a few years on you all, so give me a break here. But you know, Dr. Garcia is a very well-known public health nurse, and public health nurses have done a lot of good for this country and for Africa as well as other places in the world. But I just wonder if you could comment a bit on the fact that I didn't hear you say much about nursing as you were talking about this program, and why is the nursing school so much younger than the medical school?
Okay, so I can answer the first question, and then I'll leave it on colleagues to answer the second question. The first question I didn't mention physicians either. In the visits, so there have been more than 30 million visits to AMPATH clinics. Only 1 out of 10 is a physician seen. 10 out of 10 there's a nurse seen. So the nurses direct the care at these health centers, and both as just managing the clinics themselves, but also in navigating the patients through them. So it's fundamentally a nurse-run program. It's not a physician-run program. There's literally not a physician seen because the patients are predominantly doing well. So it's only the new patients and the ones who aren't doing well is seen by a physician. Otherwise, the nurses manage everything. So it really is a nurse-run program, and I apologize for not making that clear, but that is. As far as the history, I can let these two, because I know the history, but it's their history.
Okay, the nursing program in Kenya began in 1998, while the medical school began in 1990. We came in as part or as a department under the School of Medicine from 1998 till 2011. So we've been there from 1998, but as a department under the School of Medicine, and so did the Public Health School and even the School of Dentistry. So we began as a Faculty of Health Sciences, but majorly the School of Medicine. Secondly, I want to say that nursing in Kenya are both at diploma level, like associate, and the degree level. The degree level in nursing began late in the day. It began in 1998 in a private institution. The University of Nairobi began in 1992, then we came in 1998. So the BSN program is reasonably young, but we have grown. Yes, thank you.
Yeah, so I think the center that was shown, the Mosoriot, it's a rural health training center where we send our students. For a long time, it was run by a nurse.
Irene.
Irene,
yes.
She's another force of nature.
Yes. Yes, so she ran the center for a long time until it became extremely busy and they had to hire more staff, and then they got clinical officers who are like physician assistants, and then later they have been able to recruit young doctors to help run the facility. So we, in our setup, we don't notice the difference because we focus on what the patient needs rather than who's providing it at that particular time. And so I have a colleague who's a nurse trained in mental health who at that same center runs the mental health services in that center, including prescribing medication for common mental conditions and then consulting and referring for more complicated issues. But we focus on how many patients get care when they need it rather than who gives the care. And this is one of the problems when we are discussing health systems and health disparities in our setting, that people keep talking about ratios. How many nurses per population, how many doctors per population, and so on. I am of the opinion that those ratios are useless. They don't make sense. So what if you have 100,000 doctors for 1 million patients? Are patients getting the care they need when they need it? I think that is a more important metric than thinking about how many people have been flooded into the region. And so when you focus on that, then you think about who can deliver that care quickly, safely, and effectively for the patients. Then it doesn't really matter what the designation of that person is. It matters that they are able to deliver the care safely for these patients when they need it. So I think this is a kind of thinking that we would like to promote in the work that we do. Thank you.
So thank you very much, Professors Atwoli, Telagat, and Tierney. Thank you to you all for coming, and special thank you to the School of Nursing for hosting this lecture. Please join our guests